Which of the following statements regarding tricyclic antidepressant, TCAs, is not true? A. The TCAs are known to slow cardiac conduction. B. A common side effect of TCAs is constipation. C. The TCAs are more effective than stimulants. D. The TCAs are often administered in divided doses to reduce side effects. E. The TCAs are rarely used to treat children with ADHD. The answer is C. The TCAs have a substantially worse side effect profile than stimulants and are less effective for treating ADHD. Children taking TCAs have experienced several untimely deaths. The slowing of cardiac conduction and an increase in the PR and QRS intervals on an electrocardiogram, ECG, are examples of cardiovascular adverse events. Findings from neuroimaging studies of subjects with ADHD include which of the following? A. Reduced perfusion in bilateral frontal areas on positron emission tomography, PET. B. Increased perfusion in prefrontal, striatal, and thalamic regions in response to methylphenidate administration on PET scan. C. Dorsal anterior cingulate cortex, DACC, dysfunction on functional magnetic resonance imaging, fMRI. D. Abnormalities in frontostriatal brain regions on various imaging techniques. E. All of the above. The answer is E. The understanding of the genesis of ADHD has advanced greatly as a result of neuroimaging techniques. It is believed that frontostriatal brain areas are involved in crucial processes that are primarily mediated by cognition, working memory, attention, self-regulation, and other processes. Which of the following statements describing the genetics of ADHD is true? A. The risk of ADHD for a sibling of a child proband with ADHD increases up to 5 times in some studies. B. Children with ADHD are at no greater risk of developing conduct disorder than children of similar ages without ADHD. C. Concordance rates for ADHD range from 25 to 40% for monozygotic twins. D. Concordance rates for ADHD range from 5 to 10% for dizygotic twins. E. The heritability of inattention-related behaviors is estimate to range. The answer is A. There is a lot of strong evidence that ADHD has a hereditary foundation. The majority of published controlled family studies show that first and second-degree relatives of probands with ADHD had significantly higher rates of ADHD than healthy control participants. Possible acquired etiological influences in ADHD include A. Low socioeconomic status. B. Elevated intake of sugar-containing foods during early childhood. C. High birth weight, above 4,000 grams. D. Prenatal exposure to alcohol or nicotine. E. All of the above. The answer is D. Alcohol and nicotine use during pregnancy has been shown to significantly increase the risk of developing ADHD and other cognitive and behavioral issues. Within populations of persons with ADHD, the influence of these factors seems to be more constrained than that of familial or genetic factors. Which of the following statements about ADHD is false? A. Children with ADHD can have inattention with no hyperactivity or impulsivity. B. Children with ADHD may have symptoms of hyperactivity but not inattention. C. The disturbance in behavior must occur in at least 2 settings. D. Children can meet the criteria for ADHD with impulsive symptoms only. E. Many children with ADHD have many symptoms of inattention, hyperactivity, and impulsivity. The answer is D. Numerous indications of ADHD in children may include being impulsive, hyperactive, and inattentive. children cannot just exhibit impulsive symptoms and meet the criteria for ADHD. They must also show signs of either hyperactivity or inattention. There must be a disruption in two or more contexts. The first symptom of ADHD to remit is usually A. Hyperactivity, B. Distractibility, C. Careless mistakes in schoolwork, D. Impulsivity, E. Learning difficulties. The answer is A. In the course of the disorder, hyperactivity is typically the first symptom to subside. The course of ADHD is generally highly diverse, and symptoms may disappear around puberty or continue until adulthood. Remission before the age of 12 is uncommon. When it does happen, it often happens between the ages of 12 and 20. Hyperactive and impulsive children are often A. Accident-prone, B. Explosively irritable, C. Unable to resist blurting out answers, D. Excessively talkative, E. All of the above. The answer is E. Very active children are frequently reckless, explosively irritated, talkative, and reluctant to relax quietly. They are emotionally unstable, and this makes it difficult to predict how well they will perform in different situations. The youngster and the parents frequently appear to be perplexed and shocked by these responses. Diana is a 9-year-old girl brought in for her first psychiatric consultation by her parents, who were troubled by Diana's behavior during the Thanksgiving holiday. Diana's mother described Diana's propensity toward interrupting others' conversations, her inability to stay seated at the dinner table for longer than several minutes at a time, and her frequent and brief but very noticeable bouts of sullen mood. Both parents reported that Diana's quirks have been observable throughout her life. They described her as moody, stubborn, turbocharged, impulsive, and a bit aggressive with others, traits that they have noticed since she was an infant. Academically, Diana thrived in certain classes, particularly those in which she was immediately engaged with the material, but she also struggled mightily with certain subjects, particularly reading and writing. Distractibility also caused significant problems. Teachers frequently commented on the need to seat Diana away from the windows and at the front of the class in an effort to maintain her focus on the lesson. The teacher also commented that Diana rarely stayed in her seat for more than a few minutes at a time and made frequent visits to the bathroom and drinking fountain. Diana was resistant to meeting with the psychiatrist and was feeling grouchy when the interview began. During the interview, after initially sitting in a chair with her arms crossed, she walked around the psychiatrist's office, examining objects within reach, at one point perching perilously on the edge of an end table in an effort to reach a book, responding only to the psychiatrist's repeated insistence that she not climb on the furniture. The diagnosis in the case above is A. ADHD, B. Anxiety disorder, C. Bipolar I disorder, D. Conduct disorder, E. Expressive language disorder. The answer is A. Many kids with ADHD experience secondary depression as a result of their poor academic performance and ensuing low self-esteem. A primary depressive disorder, which is likely to be characterized by hypoactivity and withdrawal, must be separated from this condition. Directions. Each set of lettered headings below is followed by a list of numbered words or statements. For each numbered word or statement, select the one lettered heading most closely associated with it. Each lettered heading may be selected once, more than once, or not at all. A. Methylphenidate, Ritalin. B. Dextroamphetamine, Dexedrine. C. Bupropion, Wellbutrin. D. Clonidine, Catapress. E. None of the above. This drug is favored in children with ADHD and a history of severe tic disorders, and may be particularly helpful when ADHD symptoms are pronounced in the late afternoon or evening. The answer is D. Clonidine, catapres. This drug has a short half-life and has been shown to improve symptoms in approximately 75% of ADHD-diagnosed children. The answer is A. Methylphenidate, Ritalin. This drug may be favored in children who experience significant rebound symptoms from stimulants or in children with comorbid ADHD and depression. The answer is C. Bupropion, Wellbutrin. This drug has a half-life of 8 to 12 hours and is approved in children as young as 3 years old for treatment of ADHD. The answer is B. Dextroamphetamine, Dexedrine. Growth suppression occurs during treatment with this drug, but studies indicate that children recoup the growth when given drug holidays over weekends and vacations. The answer is A. Methylphenidate, Ritalin. Some of the most well-known drugs for the treatment of ADHD are methylphenidate, dextroamphetamine, and mixed amphetamine salts. When used to treat ADHD and tic problems, which can be made worse by stimulant use, clonidine is a wise choice. Methylphenidate's short half-life might cause rebound symptoms in certain kids, such as increased irritability and hyperactivity. Bupropion may help some people with comorbid depression who gain from the antidepressant properties of the drug. Directions. Each set of lettered headings below is followed by a list of numbered words or statements. For each numbered word or statement, select the one lettered heading most closely associated with it. Each lettered heading may be selected once, more than once, or not at all. A. ADHD, inattentive type. B. ADHD, hyperactive impulsive type. C. ADHD, combined type. D. All of the above. E. None of the above. Most common. The answer is C. ADHD, combined type. Least common. The answer is B. ADHD, hyperactive impulsive type. Most children identified as having this subtype were 3 to 4 years younger than children diagnosed with other subtypes. The answer is B. ADHD, hyperactive impulsive type. These children are often described as sluggish, anxious, and sleepy. The answer is A. ADHD, inattentive type. Some of the symptom diversity associated with ADHD is described by the inattentive, hyperactive impulsive, and mixed subtypes of ADHD. The combination kind is more prevalent among kids who are referred to clinics for diagnosis and treatment, followed by the inattentive form. Because they display fewer oppositional, rebellious, and aggressive behaviors, children with ADHD are more likely to be diagnosed later in life.